So I'm going to talk to you today on transcutaneous CO2 monitoring in the diagnostic sleep medicine. The objectives today, I'm going to discuss the importance of monitoring CO2 during your overnight sleep studies. You'll also be able to identify 3 reasons why oxygen saturation monitoring alone is not going to be enough. We're going to talk about the advantages and disadvantages of the different types of CO2 monitoring that we do. And you'll also understand why it's important on how you're monitoring when it comes to ventilation perfusion mismatch. I do have a disclosure, and that is I work for Syntec. When I started working for Syntec, as Candy mentioned, my background is in neonatal ICU. We use transcutaneous monitoring in neonatal ICU all the time. It's so important for those kids to keep their CO2 in check. It has huge impacts on both their lungs and their brains. So when I came on board with Syntec, I was talking to a sleep lab and I was asking them, well, how do you monitor CO2? And they said that they weren't monitoring CO2. And I realized then that we've got this great technology out there that can really be beneficial in the sleep lab that we're underutilizing. So today we're going to talk about why we should monitor CO2 in sleep patients, where oxygen saturation monitoring alone comes up short. We're going to talk about the different types of CO2 monitoring that we do. Of course, I'm going to get deep into ventilation perfusion mismatch, and I'm going to then reveal why transcutaneous CO2 monitoring is such a great fit for the sleep labs. First thing I want to do is find out what types of patients you're monitoring in your sleep labs. How many of you guys are monitoring adults? Okay, most of you. Anybody monitoring pediatrics? A few? How about neonates? Not so much. Okay, very good. So let's talk about why these patients are coming into your sleep labs in the first place. Well, we know that there's increased prevalence and increased awareness in sleep disordered breathing in a lot of different patient populations. Maybe it's related to obesity or flare-ups of lung disease. Of course, you've got those neuromuscular disorder patients. But it can be other conditions, even in those patients who are normal weight. Interestingly, we've got a study here that's saying that 95% of patients who underwent prolonged mechanical ventilations will have sleep disordered breathing. And I think that's fascinating. And the first thing I thought about was these COVID recovered patients. We've got a lot of patients out there who were intubated for long periods of time. And just talking to a couple of you, you're saying, yeah, we're seeing these people with long COVID come into our sleep labs. So this is very important to remember. But let's talk about why we need to measure CO2. We monitor oxygen, and we understand the importance of monitoring oxygen, and it's easy value to get. You put a pulse oximeter on. You've got your oxygen values. When I first started, it was actually 30 years ago, and anytime we needed an oxygenation saturation on a patient, they'd call the RT. Not so much anymore. Now you can order it on Amazon and find out your oxygen saturation, right? But it's important to remember that oxygenation and ventilation are separate functions of the same system, and they need to be monitored separately. And we do see high carbon dioxide levels in patients who frequently come into the sleep labs. Up to 46% of your pediatric patients who have sleep disordered breathing will have nighttime increases of their CO2 of 10 millimeters of mercury. 17% of adults who have obstructive sleep apnea also have hypercapnia at night. Oxygenation does not reflect ventilation. As I said, they are separate functions of the same system. And it's been shown, and I'll show you some studies here in a minute, that hypercapnia will be missed if you're only looking at oxygen saturation in about 30% of their patient population. Also know that adding oxygen without monitoring your CO2 can lead to worsening hypoventilation, and we really see that in our COPD patients. That's one of the first things and classic things they teach you in respiratory school. Having this additional transcutaneous CO2 value and continuous CO2 value had alerted providers the need to make pressure adjustments in 75% of IPAP settings and in 66% of EPAP settings. So having visibility to the CO2 really helps these PAP titrations. Let me ask you how you're monitoring patients in the sleep lab. I'm not even going to ask you about oxygen saturation because I know you're monitoring that. How many of you are using, for CO2, are you using end-tidal? Okay, anybody using transcutaneous out there? Okay, good. Got a lot of newbies, so I could really say anything about it and you'd probably believe me, right? So let's talk about some scenarios where oxygen saturation is going to come up short in showing a patient's full ventilatory status. I keep on trying to move that, touch screen it. So this study, we have the transcutaneous CO2 values, and we've got the pulse oximetry values of patients who had neuromuscular disorders. These patients also had nocturnal hypoventilation. The researchers found that 41% of these patients who had nocturnal hypoventilation, the signs and symptoms of it, had CO2 abnormalities. So this chart is going to look at these patients who had abnormally high CO2 values, and it's going to tell us if their pulse oximetry values would have reflected that. And it uses 3 different saturation thresholds, one being 92%, one being 90%, and one being 88%. Now in each group, what the researchers found was that the majority of patients who were hypercapnic, so they had abnormal CO2 measurements, they still had relatively normal pulse oximetry measurements depending on which threshold they used. In this study, they also found that there was no correlation between sleep-disordered breathing and CO2 abnormalities. So they learned that they can't rely on the oxygen saturation to let them know about high CO2, and they also learned that they can't rely on just looking at the patient and seeing that they have sleep-disordered breathing to let them know if their CO2 was high. Pulse oximetry has also been shown to be a poor predictor of hypercapnia on children who are on long-term non-invasive ventilation. This study looked at 50 children who are on non-invasive ventilation, and they found that 42% of them had CO2 values that were abnormal while still remaining a pulse oximetry value above 90%. So that's really relatively normal. These results show that you can see abnormal CO2 values, but then normal CO2 values. And it underlines that oxygenation and ventilation are separate functions of the same system. Now in this study, only 3 of the 21 patients who had high CO2 at night had high CO2 on their daytime blood gas. And what that tells us is that not only is pulse oximetry not a good indicator of high CO2, but you also just can't look at their daytime blood gas to see if their nighttime CO2 is rising. This third study focused on gas exchange abnormalities in patients who were on or weaned from CPAP or non-invasive ventilation. And what they found in this study is that there were 19 instances of gas exchange abnormalities, and only 2 of those instances were represented by the patient's oxygen saturation. The other 90% of gas abnormalities was represented by CO2. So what all these studies confirm is that pulse oximetry alone is not sufficient for detecting hypoventilation, particularly in neuromuscular patients, and particularly in patients who are on and weaned from CPAP or non-invasive modes. Okay, so it's obvious we've got to be monitoring CO2 in these patients. Let's talk about how we monitor CO2 in these patients. First, we've got your traditional blood draws, so ABGs. This is going to be the gold standard for accuracy, but they're painful, and so they're not a great fit for the sleep lab. You don't want to wake up that patient, right? We've also got end-tidal CO2 or capnography. That's going to measure the CO2 in a patient's exhaled breath. And that's nice because it's non-invasive and it's continuous, but its accuracy is going to depend on the quality of the airway, and it's going to be affected by any type of lung compromise. It's also going to be affected by what type of ventilation method you're using if you're using a respiratory assist device. Third, we have got transcutaneous CO2 monitoring, and I'm going to talk about that, of course, in depth later. This is also non-invasive and continuous, like your end-tidal, but its accuracy is independent of your ventilation method and independent of any VQ mismatch you're getting in your patient's lungs. You've got to consider the perfusion at the site. Poor perfusion at the measuring site can impact your values. We are going to take a closer look at each one of these methods. Of course, we'll begin with your ABGs or your arterial blood draws. Sometimes in pediatric patients, you'll get a capillary blood draw. But let's talk about blood draws. Because they measure the blood directly, they are the gold standard for knowing what your CO2 is. They're also going to give you access to multiple parameters. So you're going to be able to know the patient's pH and their oxygen level and their bicarb levels, which really gives us some insight to any elevated CO2s and how long it's been going on. The thing is, blood gases are painful, and it says that they can be painful. Well, I've had one done. They're painful. So they're painful, so they're not a great choice for the sleep labs because you're trying to prioritize a patient's sleep. They are also just a point-in-time measurement. So if you're doing a blood gas before the study and then maybe halfway during the study or after the study, there's a lot that can be going on in between those data points that we don't have visibility to. It's also recommended not to use your daytime blood gas to find out what's going on at night with these patients. As I mentioned before, studies have shown that many patients who have overnight events have normal CO2 on their daytime blood gases. And this study refers to that concept. So this study looked at 21 pediatric patients that were monitored with a blood gas during the day and then again at night. What the researchers found was that 85% of these patients who had nocturnal hypercapnia did not have hypercapnia on the daytime blood gas. So this evidence further emphasizes that looking at your daytime CO2 level has minimal predictive value on your nighttime CO2 levels, and it really underscores the importance of monitoring carbon dioxide level in those children who are receiving overnight respiratory support. Now, I love a good graph, and I love this slide. The other huge limitation of blood gases is that they are not continuous. So everything happening in between those point-in-time measurements goes undetected. Here's a great example of this. Here is an overnight trend of a patient who has hypoventilation syndrome, and here are our blood gases. Now let's connect those dots and see what the trend looks like. Doesn't look too bad to me. Looks like he gets a little hypercapnic in the morning, but other than that, he looks pretty good. Fortunately, we've got the transcutaneous values for this patient as well, and this is what they are. And we can see that there's a lot going on in between those blood gases that we just don't know. And in fact, this patient spent more time outside of desirable CO2 ranges than he did inside desirable CO2 ranges. And what I think is interesting about this is you can see that your transcutaneous values also align perfectly with your blood gas values. And this first blood gas that looks like it was done at about 3 o'clock in the morning, I would imagine this patient woke up for that blood gas, and that's why he blew off CO2. Whoa. I like to tell people that I'm RT, not IT, so whenever these technical glitches happen, they're going to... Exactly, yeah. I know, it seems kind of mean, right? Exactly. So he summarized the limitations. There we go. So the limitations of arterial blood gases the biggest one is that they only represent that point in time. They're difficult to perform because you're trying to protect your patient's sleep. Daytime blood gases have minimal, if any, predictive value on your nighttime blood gases. And they do require a trained staff, which most of us are. So overall, they are the gold standard, but they're invasive and painful. They're going to disrupt the patient's sleep. And ultimately, they're just a snapshot of what's going on at the time of the blood draw. And these patients have a very potentially variable ventilatory status overnight. We just don't see that with blood gases. So let's talk about the next method, which is in-tidal CO2 monitoring. As I mentioned before, it measures the level of carbon dioxide in the patient's exhaled breath. You might hear it referred to as end-tidal or capnography if you're getting a graph or a waveform, or capnometry if you've got a numerical value. So end-tidal's got a couple of advantages. Of course, it is continuous, so it overcomes that big limitation of your blood gases. It also gives you a nice breath-to-breath waveform so that you can really see that it's picking up. And if any of you have worked in ICUs, that's particularly important because it's going to tell you immediately if you're intubated and if the patient accidentally extubates. You don't have to worry about that, hopefully, in your sleep labs. However, there's a couple of drawbacks, especially when it comes to monitoring the patients that you frequently see in your sleep lab. First, it's going to underestimate the CO2 in patients with a ventilation-perfusion mismatch. It also gives you incomplete data when you're monitoring a patient. Maybe you're doing a split night study and you're changing the way that you ventilate a patient halfway through. It's going to give you inconsistent data when you have those patients. And it also doesn't account for any flow from the respiratory assist device or any gas air leaks from the mask. So we're going to talk about VQ mismatch. VQ mismatch represents a scenario when either perfusion to the alveoli or airflow to the alveoli is restricted or blocked. I need my notes on this. Okay. So either they're having an airflow issue or a blood flow issue, or more likely than not, a combination of both. You're going to see VQ mismatch in a high portion of patients who come into your sleep lab. It's the main mechanism of gas exchange abnormality in those patients who have asthma. Obstructive sleep apnea can be a cause of congestive heart failure, so you get a VQ mismatch if they've got any pulmonary edema associated with that. VQ mismatch is also the principal contributor to hypoxemia in those patients who have COPD. They've got airflow limitations, but they've also got destruction of the pulmonary capillary beds, so they've got a little bit of ventilation and perfusion issues, and so you're going to get a big VQ mismatch with these patients. As with obesity, as with apnea, obesity hypoventilation syndrome can also cause hypercapnic respiratory failure, and you can have some pulmonary edema with that and a VQ mismatch. And these diagnoses make up a large portion of the patient population that you see in your adult sleep lab. Now let's take a look into why VQ mismatch matters when you're talking about how you're monitoring your CO2. I have to take a little sip before I do this, because that last one had a lot of words on it. All right, let's everybody take a deep breath. And let's take a look for reference how normal, healthy lungs should look and how they should work. So presumably most of us have normal ventilation perfusion. When we breathed in, we brought in air and oxygen. It went to our alveoli, diffused into our bloodstream so that we can oxygenate ourselves. CO2 takes a reverse course. Our CO2 went from our bloodstream into our lungs, and we released it when we exhaled. Now, if you have normal ventilation perfusion, your exhaled CO2 is likely going to match your blood CO2, which, to me, if you really think about that, that's pretty impressive that we can get our blood CO2 by looking at our CO2 in our exhaled breath. That's in normal, healthy lungs, right? So let's talk about lungs that are not so healthy. So patients who have asthma, obstructive sleep apnea, COPD, tracheobronchial malaise, they've got restricted airways. So I just restricted that airway. When they're breathing in, they're not pulling in as much oxygen and air to get into their bloodstream. And when they're exhaling, they're not able to exhale all that CO2 because of the restricted airway. So what happens when you're monitoring this patient's end-tidal CO2 is that you're getting an underestimation of your CO2 because it's not being exhaled properly. More severe scenarios of VQ mismatch can be due to shunting. A shunt is going to be an obstruction of the airway. Maybe this is caused by pneumonia or pulmonary edema, pulmonary hypertension. But oxygen and carbon dioxide are not able to pass that shunt. So you're not pulling in the air that you need, and of course you're not exhaling the CO2 that you need to exhale. When you're monitoring a patient's end-tidal in this scenario, you're not getting an accurate value because they're not exhaling it accurately due to that shunt. Okay, let's talk about a mismatch due to impaired blood flow. In this case, the patient's breathing normally, but they have reduced blood flow for some reason. Maybe it's impaired cardiac output or vasoconstriction due to hypoxia. Regardless, you've got a decrease of blood flow to your lungs. So when you breathe in, not all the air and oxygen that you're breathing in is able to make it into your blood, so that you're not able to oxygenate as well. And your CO2 can't get out of the bloodstream to be exhaled properly. So in this case, your exhaled CO2 is not reflected of your blood CO2. Once again, it underestimates your blood CO2. Now, of course, we've got to look at a more severe condition, or if your perfusion worsens, you might develop areas of dead space. Now, an area of dead space is where you have normal ventilation but no lung perfusion. So, of course, in this scenario, oxygen is inhaled, goes into the lungs, everything's good, but it can't even get into the bloodstream at all because there's no perfusion to that part of the lung. CO2 can't get out of the blood to get into the lung to be exhaled. As you may have guessed, again, you're going to get an underestimation of your CO2 if you're just looking at your end-tidal value. So in all cases of ventilation perfusion mismatch, whether they're from ventilation or whether they're from perfusion, or most likely a combination of both, your end-tidal value is going to underestimate your true arterial CO2 value. Another limitation when we are talking about end-tidal readings is gas mixing. In your patients who have a respiratory assist device, end-tidal might not accurately represent the patient's arterial CO2 because the gas sample where you're pulling the CO2 contains more than just the patient's exhaled breath. This sample is going to contain the exhaled breath, but also any flow from that respiratory assist device and any leaks from the mask not fitting perfectly. And I would say properly, but proper fit is probably not the same thing as perfect fit. So one researcher states that in stable, intubated patients with no air leaks, end-tidal does have accurate correlation with your PaCO2. However, this cannot be achieved during non-invasive ventilation because continuous flow through the mask and because of those air leaks. This researcher goes on to say that transcutaneous measuring of CO2 appears to be more appropriate for the continuous monitoring of a patient's CO2. Let's talk about another limitation when using end-tidal, and that's going to be when you have a patient who's come in for a split night study. Now, this is an illustrative example of a split night study where we're monitoring the patient's oxygen saturation, their CO2 with end-tidal, and their heart rate. In the beginning of this study, we see that the patient's CO2, and here's where the mask use starts. Now, in the beginning of this study, we see the patient's CO2 right around 35, 37. That looks pretty good. That should look pretty good to most of us. That's usually what mine is. But consider if this patient had a VQ mismatch, then this is actually an underestimation of their CO2, and you're going to use this as your baseline for the rest of the study. Now, we do see a sharp dip in that CO2 value. Most of us would assume that that is not accurate. Probably the monitoring device was dislodged. Maybe the patient knocked it off of their nose or pulled it out completely. Maybe it's a pediatric patient and they just don't want that on their nose. But regardless, that's not going to be an accurate value. Next, after mask use starts, we do see that CO2 drop, and we say, okay, great, the respiratory assist device is working. Or is it? Maybe you've got some gas mixing and air leaks, and that's causing a lower CO2 value because of that. So what happens is that when you're using end-tidal for this type of to monitor through this type of study, you come up with more questions than you do with answers. The continuity of data really comes into question. So our limitations with end-tidal, we talked about ventilation perfusion mismatch. I hope you guys all feel real good about that. End-tidal is frequently and more often than not going to underestimate the level of your arterial CO2 in those patients with asthma, obesity, COPD, and other conditions that cause a VQ mismatch. For those patients who are on non-invasive ventilation, end-tidal is going to misrepresent your CO2 due to gas mixing and air leaks. During split night studies, the respiratory support is going to change, and this can affect your end-tidal measurement. We need to be aware of these changes when evaluating an overnight report in order to determine the patient's treatment plan. So I talked a little bit about those non-compliant patients, but end-tidal monitoring is always going to rely on that monitoring device to remain in place for an accurate value. Okay, we can move on to transcutaneous monitoring. Now, transcutaneous monitoring is going to be compatible with all types of ventilation, whether they're on non-invasive or high-flow types of support. And they're going to be accurate despite your VQ mismatches. It also measures independently of the patient's respiratory rate or tidal volume. It's just not relying on that exhaled gas for the sample. You can continuously monitor patients who are on split night studies without having to worry about your measuring device and if you're getting any air mixing with that. The sensor that's placed on the patient does require regular calibration, so generally every 8 hours in your neonatal sleep studies and up to 12 hours in your pediatric and adult studies. The other thing is that it's perfusion dependent, so those patients who have severe systemic perfusion issues, the data may be compromised because of that. So those patients may be a little bit challenging to monitor with this mode. Typically, we don't see that a lot in the sleep labs, though. So how does it work? A sensor is placed on the patient's skin, and it gently warms that site to encourage perfusion to the site and also to encourage the CO2 to diffuse across the skin. And what the sensor does is it picks up the CO2 that's diffusing across the skin, goes into the sensor, a reaction takes place, and then algorithms will use that data to give us an estimate of our arterial CO2. So it's very, like I mentioned before, it is important to pick a site that is pretty well perfused. Now, transcutaneous monitoring can overcome the limitations of pulse oximetry monitoring alone, blood gases, and end-tidal readings. This type of monitoring is going to allow you for better detection of hypercapnia, especially when you're looking at pulse oximetry alone, and it can be used to guide ventilation titration, which I think is super, super important. Unlike blood gases, it's continuous and it's non-invasive. And it also avoids the issues that I talked about with end-tidal monitoring when it comes to gas mixing or ventilation perfusion mismatch. Here is a very interesting example of a split night study. This is an overnight tracing of a patient who started the first part of the night on just straight up room air. So this part that I highlighted, that is the room air portion of this study. The orange tracing is the patient's oxygen saturation. The green tracing is the patient's transcutaneous CO2 value. So we look at that oxygen saturation and it's upsetting all of us, right? His oxygen saturation is in the 70s, it's in the 90s, it's all over the place, and this is not good news. But when we look at the CO2, his CO2 looks great. It's right around mid-40s, so we like that. But we don't like the oxygen. So the researchers in this study placed this patient on 2 liters nasal cannula. And then we like the saturations. They stabilized out very, very nicely. But look at what's happening to the patient's CO2. It's rising steadily over the course of the time this patient's been on 2 liters, and it spikes up into the mid-60s. And we notice when it spikes up into the mid-60s, that's when we see the drop in the patient's oxygen saturation. So we don't know that this patient's in trouble until it's been climbing, climbing, climbing. Fortunately, we did see this, the researchers did see this patient's CO2 levels climbing, and they transitioned this patient down to 1 liter nasal cannula, and that allowed them to stabilize the oxygen saturations and also keep the CO2 in a more stable as well. So having visibility to that transcutaneous value really helped guide the researchers in this particular patient to balance out the ventilation status and the oxygenation status. Now you guys are probably missing the VQ mismatch slide, so here we go. We're going to take a look at how transcutaneous performs better in patients who have a VQ mismatch. So this is the illustration of a reduced airflow example. So oxygen's coming in, but it's not coming in that great, and CO2 is being released, but it's not being released that great. Well, when we know that when we measure the patient's exhaled CO2, we're not getting an accurate value because we're measuring at the airway. But when you're monitoring the patient transcutaneously, you're bypassing the airway altogether, you're reading what's diffusing across the skin, and it's going to correlate better with your arterial CO2 that you're seeing on your blood gas. So the transcutaneous monitoring is going to provide a better estimate of your CO2 than your in-tidal monitoring. Okay, let's look at the issue of data congruence and continuity in those split night studies. Here we've got, again, that illustrative example of a split night study, and I've just added the transcutaneous CO2 line, which is the green line above that orange in-tidal line. Now the first thing we notice is that the CO2 line is a little bit higher. It's not underestimating any VQ mismatch. We don't see that sharp dip that came from when the monitoring device got dislodged in our in-tidal patient. When mask use starts, we do see a slight decrease in the CO2, and we can be confident that that's because of our respiratory assist device doing its job and not any gas mixing or air leaks. So, and patient compliance doesn't really factor in because they're not going to knock that measuring device off. So what all of this means is that with our transcutaneous monitoring, we have a more accurate representation of our patient's overnight ventilatory status, even when you're changing respiratory support. So transcutaneous has been shown to have better correlation than in-tidal when you're, specifically to your patients that you see in your sleep lab. This first example is in neonatal and infant patients. In this study, the correlation of the transcutaneous values and the in-tidal values were compared to a patient's venous blood gas. The results from the transcutaneous measurements are shown here on the left, and we can see that there's a mean difference of less than 2 points. When you compare that to the in-tidal values on the right, we can see that the in-tidal values, the mean difference is just over 15 points. It's also been shown to have better correlation than in-tidal in those patients that you those adult patients that you see in the sleep lab. So in this study, it looked at it looked at obesity, and what they found was they were comparing the transcutaneous value to the arterial value in patients who had obesity hypoventilation syndrome. And what was found was that the majority of the time, so 83% of the time, these patients' transcutaneous value was closer to the blood gas than their in-tidal values were. Now, I talked about how transcutaneous monitoring avoids the issues of ventilation perfusion mismatch, and this study really highlights that. This study took a look at patients who are on 1 lung and 2 lung ventilation. So if you're not familiar with 1 lung ventilation, it's a forced scenario of ventilation perfusion mismatch where for some reason we're only ventilating 1 lung. And typically you're not going to see that in the sleep lab. Where you're going to see that is in surgery type of patients or patients who've had a lobectomy. So in this study, they compared the transcutaneous values and the in-tidal values to the blood gas. Those patients who are on 2 lung ventilation, the transcutaneous value was closer to the blood gas 66% of the time. But those patients who are on one lung ventilation, so those with a severe VQ mismatch, those CO2 was closer to the blood gas values 86% of the time. So that made a big, huge difference in that particular patient population. Now, it's also been shown to outperform end-tidal in patients who have COPD, of course, another VQ mismatch scenario. Here we have a real-life example of a patient. It's a 1-hour tracing of a patient who has COPD. The dark line, hovering right around 50 millimeters of mercury, are going to be your transcutaneous data points. The white dots, ranging from 35 to 60, are your end-tidal measurements. We also have 2 arterial blood gases, and those are the red triangles in the beginning of the study and about halfway through. So this guy got a lot of blood gases in a short period of time. Hopefully he had a heart line, right? So if we focus on the end-tidal measurement, you're going to assume that this patient's CO2 is normal most of the time. But if we look at the transcutaneous values and the arterial blood gas values, we see that this patient was actually outside of what we would consider a desirable CO2 range for the whole tracing. Now, I know this is just one patient and a 1-hour tracing, but the point remains that you do get an underestimate of your CO2. You're going to get good correlation with your transcutaneous value and your arterial CO2. And this is particularly important in your COPD patients. I was listening to Dr. McIntyre, the first talk that he gave, and he was talking about these patients who are chronic lung retainers, chronic CO2 retainers. Their morbidity and mortality is much higher than patients who don't retain CO2, and they get into trouble a lot faster than patients whose CO2 does not run high on a normal basis. So it's super important to watch those patients very closely. I have got one more slide, if I haven't already convinced you enough, that looked at end-tidal and transcutaneous measuring. The end-tidal measurements here are in blue, and the transcutaneous measurements are in orange. We can look at the green bar, which is what's generally considered the limits of agreement. We can see transcutaneous values falling within those limits of agreement, and the end-tidal values falling below that. So all of these studies highlight the fact that end-tidal underestimates CO2, particularly in COPD patients, whereas transcutaneous, you don't run into that problem. Okay, so there's a lot of challenges that need to be addressed in the sleep lab in order to get a great overnight study. You don't want to wake up the patient, but you need to keep that mask in place. You know that pulse oximetry alone doesn't reflect your patient's ventilatory status, but you don't want to wake up that patient by sticking them for a blood gas. And you know that you can't always rely on your end-tidal values to be accurate, especially in patients that we see in our sleep labs. You also want the patient to get up, to remain comfortable, to be able to get up and use the restroom without much hassle. So transcutaneous monitoring can provide this continuous monitoring and help you overcome a lot of these issues that you see in the sleep lab so that you can get a good study. Let's talk about accuracy. Accurate transcutaneous values that do correlate with the blood gas are key to helping you assess the patient's ventilatory status and make good recommendations. The information I have here on the right, we've got accuracy data demonstrated across several different patient populations. This looked at patients who, pediatric patients, patients on one lung ventilation, and COPD patients who had trachs, and we found the accuracy data on all these patients very, very tight. Now, some of you may have used transcutaneous in the past, and questions of safety often come up, especially when it comes to skin integrity. As I had mentioned, the sensor does gently warm that site. The good news is our transcutaneous technology has evolved over the years, and it allows for safe monitoring across all patient populations. And when we talk about skin integrity, mostly we're talking about neonatal patients. We've got 2 studies here that demonstrate how clinicians are able to monitor with transcutaneous monitoring in premature infants who are in the NICU and in pediatric patients who are in the sleep lab. They monitored these patients for up to 12 hours without any adverse skin effects. Now, you want to use technology that's trusted, right? transcutaneous monitoring has been recommended by respiratory organizations. The AAST states that arterial or transcutaneous CO2 are the recommended methods for detecting hypoventilation during PAP titrations. The AARC notes that transcutaneous monitoring can have an increased role in detecting sleep hypoventilation and in assessing the efficacy of our treatments that we're using for sleep disorders. It's not only recommended by organizations here in the United States, but it's also recommended by respiratory and sleep organizations globally. So in addition to the AARC and the AAST, the German Sleep Society states that diagnosis should be performed via nocturnal blood gas analysis or via nocturnal measurement of transcutaneous or end-tidal CO2. So what they're saying is, yes, please look at your CO2. But they go on to say that transcutaneous technology is recommended as the most sensitive method for demonstrating the presence of sleep-related hypercapnia. The French Health Authority states that during PSG for the diagnosis and the follow-up treatment for hypoventilation hypoxemia syndrome or congenital central hypoventilation syndrome, that nocturnal transcutaneous monitoring is necessary in children and desirable in adults. One researcher highlighted transcutaneous technology, saying that since transcutaneous CO2 monitoring is non-invasive, it doesn't disrupt the sleep quality of the patient, and it provides a more complete picture of alveolar ventilation than intermittent CO2 information alone. Transcutaneous monitoring should become the preferred technique for assessing alveolar ventilation during nocturnal non-invasive ventilation. So let me summarize, and I'm coming in under my time, so that's exciting. They told me I had to stay on time or I'd be escorted out. So let me summarize what we talked about today. We've seen that monitoring pulse oximetry alone in the sleep lab is not enough, and it causes us to miss a lot of gas exchange abnormalities, hypercapnic events, and hypoventilation. Arterial blood gases, of course, they're accurate, but they are a point-in-time measurement, and they're logistically not suitable for your sleep lab. Blood gases taken during the day also do not reflect what's happening at night. End-tidal works well in some situations. It can be adequate, but it does underestimate the CO2 in those patients with a VQ mismatch, also in patients who are on non-invasive modes, and it fails to provide great data when you're doing a split-night study. Transcutaneous CO2 monitoring has been shown to be accurate and safe. It's trusted by many respiratory organizations, and it's got better accuracy specific to the sleep lab population than end-tidal. It gives you a more complete picture of what's happening to your patient's overnight course than blood gases do. So it overcomes the limitations of ABGs, oxygen saturation monitoring alone, gives you continuous CO2 reading, it's easy to use, comfortable, and really well tolerated by the patient. That brings me to the end of my talk. I hope that this was informative to you guys, and I welcome any feedback or questions. Yes? Uh-huh. Okay. Yeah. Yeah, it is very important. I believe a recording of this is going to be made available to them. Do we know that? Okay. So come up and talk to me afterwards, and I'll get that information to you. We don't typically give out these slides because of we really need it to be delivered with the right context. So we want to make sure that it's accurate. Oh, 100%, 100%. Yeah. Come see me after, and I'll hook you up with your territory manager, who he's sitting in the back there. But yeah. Yes. Uh-huh. Right. That's a great question. And keep in mind that there's a couple of different transcutaneous technologies out there, and those technologies that use the digital technology, you don't have to change that site every 2 or 4 hours. It can remain in place for 8 to 12 hours.
There's no contraindications of diabetic patients that have skin issues or organ.
So if you have a patient who's got skin issues, then that is something to take into consideration when you're monitoring that patient. So it may be that you need to check that site once, or if they're sensitive to any type of heat, you would take that into consideration, just like you would all the other things that you put on your patients. If it's not magical. It'd be nice if it was. But yeah, those patients are you'll have to consider that. Yeah.
The degree of warming is a lot less than we use.
It is a lot less. Some technology out there uses 42, 43, 44 degrees. Digital technology is going to use 41 or 42 degrees. So it's a slight warmth, but it's by no means hot. And those adverse skin effects that we used to see, we just don't see those anymore.
All right. Thank you so much, Margie. We appreciate it.